Hi, everybody, and welcome. We are going to get started very soon. Just bear with us as we let people sign on. We're very excited about today's discussion. Again, welcome, everybody. We're just about getting started. I'm going to make just a couple of housekeeping announcements as people get settled on and signed on. Again, welcome. This is our first speaker series of the year. And today we're delighted to welcome Dr. Karissa Gable of Duke University Hospital, and a member of our Global Medical Advisory Board. Our conversation today will be all about variants of GBS and CIDP. Before we get started, like I mentioned, we have a few housekeeping things to get through. So, most importantly, these webinars are meant to be educational and are not meant to troubleshoot or consult on your individual cases. As always, talk to your doctor about your individual care. If you do have a question, please type it into the Q&A box towards the bottom of your screen. But again, remember that we're not troubleshooting specific circumstances. If your questions don't get answered, you can email us at info@gbs-cidp.org, and we will do our best to respond. With all of that great information, let's go ahead and get started. Welcome, Dr. Gable.
Hi, thanks for having me.
Thanks for being here. So today we're talking all about variants of GBS and CIDP, apparently a very popular topic within our community. But why don't we start? Can you give us just a quick overview of who you are and what got you interested in this area of medicine?
Sure. As you noted, I'm Karissa Gable. I'm at Duke University. I've been in neuromuscular subspecialist with a focus on inflammatory neuropathies. And I've been here for about 9 years. And I think my initial interest started actually back in residency when I was working with Dr. Allen. And so I just found that, my interest in neuromuscular medicine it's just such a fascinating field. And there's so many areas for research. And then I think ultimately, I found that I just kept gravitating towards that all through fellowship. And then here I am today. So.
Awesome. Well, let's dive right into this topic because I think we have a lot to talk about. So first, let's define variant. What does it mean when we say that somebody has a variant of GBS or CIDP? And then really, why does that term even exist?
Right. So I think for both of those kind of categories, the point or the why that exists, it really means that when you are thinking about the diagnosis for both of those entities, you're looking at how the symptoms present, how this, kind of the symptoms and how they feel and are reported to you, and that from the patients, and then also how the physical exam findings look, and those kind of combination of things give you an idea of whether or not that's going to be a typical variety or not. And so then when you get into the area of variance, that really more or less is actually how sometimes some parts can be affected more than others on the physical exam, or sometimes how the symptoms can be a little different. But then you also have the secondary kind of part of the diagnosis, which is the electrodiagnostic testing that helps kind of support those kind of diagnosis. So I think when people look at variants, or defining variants, sometimes there can be a little bit of gray zones, and sort of the variants actually are the areas where there's, especially with the CIDP, the most frequent kind of misdiagnosis, because sometimes that can be a little difficult. But we have defined sort of categories of variants for each, both CIDP and GBS. And so starting with CIDP, you have, your typical, so first you have to kind of understand the typical variety. So the typical CIDP case or symptoms are going to be kind of motor and sensory symptoms. They're going to progress beyond the course of 8 weeks. They could be relapsing, remitting, or just progressive. It's going to affect both the arms and legs. It's going to affect very similarly or symmetrically. It's going to affect the arms, up at the top, and the hands and the feet and the thighs, kind of proximal and distal distribution. And so that's going to be your typical kind of variety. And then when you get into the variants, you're going to have the distal variant of CIDP. So that one is it's still the same on both sides, but it's just kind of the hands and feet predominantly that are affected with motor and sensory symptoms. And then you get, and so that's about 7 to 15% of the types. So overall, like the variants are they're kind of in the rare category. So more in the 10 to 15% range of kind of or maybe 20%. Sometimes it's a little bit, all the data is not all that great for the incidence and prevalence, but around there. So
Let me, hold on, sorry, I don't mean to interrupt, but let's pause on the epidemiology quickly. So if we think about the prevalence of CIDP and we put that at, what do we usually say, like 30, 40, 50,000 in the US, does that sound right?
Like 1 in 100,000.
Yeah.
Yeah.
So within that prevalence, are these variants already included, or are they included in like a different epidemiologic number?
No, they're already included. Yeah.
Okay.
But I would think of it as overall, this is CIDP, and then the way it kind of shows up is a little different. And then kind of you have that the vast majority, kind of 60, 70, percent around there are about, the typical, and then you have kind of the subsets or the variants. So you have that distal type, where it's just hands and feet, motor and sensory symptoms. Then you have the multifocal type or Lewis-Sumner Syndrome. And so that can sometimes affect the arms a little bit more predominantly. And that's going to be kind of a little bit more random. So, maybe a leg and an arm, maybe, but still motor and sensory, but not symmetric, not the same on both sides, unlike the typical type.
So with Lewis-Sumner, we should give a quick mention to Dr. Richard Lewis, who was a longtime friend of the foundation and also on the Global Medical Advisory Board.
Yep.
In case he watches this later, we have to make sure we acknowledge.
Yes. And so hopefully I did that description justice. I think, and then the focal, there's so a focal limb onset, that's probably the rarest of the types, where it's really one limb that's affected, and often it's kind of at the plexus level, where those nerves are all kind of coming out from the spinal cord, either brachial, lumbar plexus. So that's rare, motor and sensory, but just one limb. And then you have motor variants, and then you have pure sensory variants. And so those are sort of the categories of the CIDP variants. And within Guillain-Barré, so Guillain-Barré typically have motor and sensory progressive weakness that peaks at a point of 4 weeks and doesn't usually progress beyond that, as far as with respect to the kind of symptoms and how they progress. Then amongst the variants, you can have, sort of motor sensory, a little bit more motor involvement. And then the variants, you can have ones that are paraparetic, where you get very rapid, almost like all, from here down, very weak and numb. And so like a tetraplegia, essentially. You can have a pharyngeal cervical brachial variant that really only kind of affects muscles up here, kind of here up. And maybe in the arms a little bit sometimes. So that's kind of the ones. And then you can have weakness of the face and just sensory symptoms in the arms and legs, but no weakness in the arms and legs. So that's one of the variants. And kind of even more rarely, you can have a pure sensory variant. And that's just, as it's described, sensory symptoms, but the nerve conduction studies support the diagnosis of being something that affects the coating of the nerve or the myelin. And then you have Miller-Fisher variant. So that is sometimes a little more mild than others. Sometimes there's some overlap with some of the other things. You can have a Miller-Fisher syndrome. Typically is going to affect the eyes, where your eyes don't move as well, or ophthalmoplegia. Difficulty walking or imbalance, or they call ataxia, and then loss of reflexes, which typically comes with all of these anyways. But that's kind of those three kind of symptoms and findings on exam that we kind of correlate to that variant. And so you can have a Miller-Fisher syndrome that sort of starts to evolve into a little bit more classic motor sensory effects in the legs too. You can also have sort of a variant of Miller-Fisher syndrome that affects the brain, called Bickerstaff brainstem encephalitis. And so that one can cause some kind of issues with confusion and cause some actually MRI brain changes too, but has a GQ1B antibody. So it's kind of part of that spectrum. So those are sort of the variants amongst Guillain-Barré.
Gotcha. So, oh my gosh, there's so many different varieties of these already rare conditions. And we talked a little bit about the distribution. So for GBS, same kind of question about the epidemiology. So we know, there's maybe X amount of cases of GBS in the US, and I'm sorry, that number is totally escaping me at this moment. I think it's 8,000 to 9,000 cases per year of GBS in the United States. So do those also include those variants, or are they separate? And then can you have, especially with GBS, can you have kind of both? Can you have traditional GBS with some Miller Fisher, or does it usually show up one or the other?
So I would say most of the time it shows up one or the other, but then sometimes you can have a little bit of overlap, and that would be considered sort of its own variant. So yeah.
Yeah.
And I would say the variants still fall under the umbrella of
the
GBS. Yeah. And
Got
then, and as you had kind of brought up, we had discussed before, you have these categories of, say, of the kind of general Guillain-Barré syndrome, you have, AIDP, which is the most common. And then you have the kind of what they say AMAN or AMSAN sort of variants, but those are categorized in that way, mostly based on what the nerve conduction studies look like. And
AIDP, can you give me the full?
Yeah, the acute inflammatory demyelinating, syndrome, or then you can have the kind of acute motor, axonal neuropathy or acute motor axonal and sensory neuropathy. And so those sort of categories are more sort of less and likely like variants, but more kind of categorized based on what the nerve conduction studies look like, and sort of thoughts about prognosis and what to expect and the degree of kind of core of the nerve being affected. And the kind of issue with that diagnostically, just as a side note, is that just it depends on when you do the nerve conduction study, is how much the time has evolved to see like how much motor or sensory involvement there is. And there's also regional, worldwide, kind of areas where there's incidences higher of some versus others. So.
Gotcha. Okay. So you actually brought up an interesting point. You talked about the nerve study. So is that really the definitive way that defines the variance, or is it a combination? And then we've mentioned motor and sensory a couple times, but I was hoping you could just define that pretty quickly.
Yeah. So I'll start with the motor and sensory. So motor, meaning on the nerve conduction studies, so we probably many of you have had nerve conduction studies, and we look at the kind of the motor nerves in the arms and legs, and those are the ones that have more involved with kind of motor function. And then you have the sensory nerves as well that are separate, and so we test those separately. And so it's kind of the combination of those things. So at least for CIDP, there are criteria or electrodiagnostic criteria that help define, is it CIDP or not CIDP, based on the new guidelines from the EAN-PNS from 2021. And so that's how those are used. With Guillain-Barré, it depends on the timing of when you do the nerve conduction studies. Sometimes if it's very early on, you might see only very minimal changes that would be expected as part of the criteria for a diagnosis or supportive for the diagnosis. So it depends on a little bit on when you do them, but then, is helpful for understanding the expectations for what to expect in the future a little bit.
Yeah, that's interesting. So we're getting a pretty good overview of variants. We're also going to talk about some of the mimics, and we've gotten a couple questions on mimics, but actually we do have some good audience questions that I'm going to throw at you in no particular order. So are there variants that exist that kind of maybe aren't defined or maybe outside of those definitions? For example, kind of weakness and sensory symptoms come and go, normal nerve conduction test. That's what somebody wrote in. But really, I think the bigger question is are there probably undefined variants still out there, or is there a mix and match of symptoms that can still kind of fall under the CIDP umbrella?
I mean, that's a little hard to answer, because I think probably that generally speaking, I would say those, I don't ever give anything 100% one way or the other. So potentially maybe, but I think probably this is our best guess for defining those characteristics. And I think really in order to avoid sort of a misdiagnosis or either under or overdiagnosis, I think it's important to kind of use those kind of clinical phenotypes, or how those things, symptoms present and how we know they present. And then that kind of brings you into the area of mimics of, what does that look like when you have something that kind of seems like it's Guillain-Barré or kind of seems like it's CIDP, sort of meets the criteria or it's a possible categorization based on the electrodiagnostic criteria. And then what do you do from there? And what other things are you considering? And so that's another reason why the variants are important, is because those like different kind of subtypes can lead you down a different path of considering what the other mimics or other alternate diagnoses could possibly be, especially if there's a lack of response to treatment or an incomplete response to treatment. And I think, we had, and then you kind of wonder about like, what does that mean to be like a refractory kind of case, or is that even, for CIDP, or is that, how's that defined, which is up for debate as well. And I think probably just thinking about the variants and then what the categorization of what other things could contribute to those symptoms would be something to always consider, which every time I see a patient, even though I'm convinced the first time, like that this is what they have, every time I see them in follow-up, I always kind of go back through that algorithm. This is a distal subtype of CIDP. Are they responding to treatment appropriately? If not, like what other things might be evolving, and kind of just keeping a close eye on those and always looking at those variants and the possible mimics.
Yeah. So you mentioned something that I think is interesting. One of the important reasons that we define variants is for good epidemiologic data and to understand kind of prevalence of disease and all of that. But then the other piece is treatment. And sometimes, we're finding variants or mimics because a treatment isn't working. So the question I have here is, are the variants of CIDP and GBS still treated the same? Is there anything special about treating those distal, the Lewis-Sumner variants, things like that? Knowing that IVIG still is typically the gold standard for both GBS and CIDP, and that there are treatment guidelines that do exist for both of these conditions now.
Yeah, I would say on the whole, the short answer is they're all kind of treated the same, and treatment, is supposed to work for those. I think there's subtleties to the longer answers of those. I think, for example, distal CIDP, a rather like large percentage of those patients have monoclonal proteins. And of those that have monoclonal proteins, they sometimes, you can determine they might have anti-Mag neuropathy, which I think we were going to discuss at some point as well, which is actually a completely different entity and responds differently to treatment. And it's kind of harder to study because it's so slowly progressive. And so with respect to research and that sort of thing, and other clinical trials that have been done. So I think that is something to always keep in the back of your mind. And those patients say that have just, distal CIDP and have a monoclonal protein and don't have anti-Mag antibodies still don't respond to treatment quite as well as the typical CIDP. So that is something about the monoclonal protein that is kind of, that's something that we've noticed. So I think that's something amongst, the distal variant we kind of keep in mind as far as treatment response. But the other subtypes typically respond to the first line treatments. Yeah.
Gotcha. Okay. I was hoping to just do a quick refresher on all of these variants, and then we'll probably move on to the mimic. So distal CIDP, can you remind me how that presents in patients?
Right. So that's going to look like kind of sensory and motor symptoms. So like foot drop or hand weakness, and kind of numbness and tingling in the hands and feet, sort of slowly progressive over the course of, beyond 8 weeks. And so that's what that would look like, with
Gotcha.
loss of reflexes or diminished reflexes.
Yeah. And one more time for Dr. Lewis-Sumner Syndrome.
Yeah, so that is going to be a multifocal sort of presentation. And so what you'll see there will be, say, for example, you might see kind of hand weakness, or and then maybe in the right arm and left leg weakness, or both arms are affected, and minimal changes in the lower extremities, or maybe that will evolve over time with numbness and tingling and weakness that's sort of asymmetric.
Yeah. So, sorry, taking a little road trip there. MMN can sometimes present asymmetrically. So I'm thinking that the difference is that Lewis-Sumner still has that sensory. Is that what I heard?
Yes.
Okay, gotcha.
Yeah.
This is like a fun quiz. I hope that I hope that you're having fun too.
Yeah.
The focal CIDP.
So focal CIDP, sort of the rarer type, and that would be just one arm, one leg, motor, sensory changes in that kind of distribution.
Focal. Gotcha. Okay. Motor CIDP. I think that's probably in the name.
Yeah, yeah, and so that's going to have motor symptoms, so weakness with no, no report of any numbness or tingling. However, that being said, on the nerve conduction studies, sometimes we can see some sensory involvement on the nerve conduction studies in motor CIDP, and we call that motor predominant CIDP. The same for the sensory kind of correlate. You have, and it's still symmetric. It's symmetric, kind of both sides are affected in the same way. And then the sensory CIDP is pure sensory symptoms, no weakness. And the nerve conduction studies are abnormal. And so that's one of the updates to the kind of guidelines criteria, is to add criteria for sensory conductions. Being careful to make sure that everybody gets warmed appropriately and quality control for the studies. But so the sensory conductions are abnormal on the sensory CIDP. However, if you have some motor nerve involvement on the nerve conduction studies, but the patients don't have any weakness, it would be a sensory predominant CIDP.
Gotcha. Gotcha. This is very interesting, and I really hope that our attendees are finding themselves kind of in these descriptions. Very quickly, let's just chat about the GBS ones. And we got a very interesting GBS question. Specific to Miller-Fisher syndrome. So let's do a quick refresher on what that looks like for a person. And then the question we got from the audience was, can a nerve conduction study be performed on the eyes?
So you can do, not on the eyes per se, but we can do something called the blink reflex. So sometimes, especially in Miller-Fisher syndrome, you might do nerve conduction studies that are normal sometimes. And so that triad of kind of symptoms are really like, are kind of ataxia or imbalance, ophthalmoplegia or eye movement abnormalities where the eyes just don't move back and forth like they should, and loss of reflexes. So that's kind of the triad of symptoms for Miller-Fisher syndrome. And sometimes, like I said, there can be a little variant overlap where you get some of the more typical motor and sensory limb changes as well with Miller-Fisher. But if it's pure Miller-Fisher, those would be the three things. And then sometimes the nerve conductions are normal, and we do something called blink reflexes, which are part of the nerve conductions response, where you kind of put electrodes here and can stimulate to look to see if there's kind of abnormalities kind of up around that area. But that's kind of the closest we get for looking there. And sometimes the blink reflexes can be abnormal in this case, and everything else from like here down is normal. So.
Interesting. Okay. And then AMSAN, also a GBS variant.
Yeah, so that, like I was saying, is sort of like the kind of sort of initially those terms kind of came up with like trying to categorize types based on how the nerve conduction studies look. The new GBS guidelines kind of say don't really rely on those categories as much, just depending on when you do the study. For example, I think I was in fellowship and I did a study very early on, and all the motor nerves were all very abnormal, and the sensory nerve connections were all normal. And so we were like, oh, is this an AMON variant? Where it's just, I mean, those kind of categories of GBS kind of global like umbrella, and then you have AIDP, which is the more kind of typical like findings of the clinical symptoms of like weakness and sensory changes, or that affect the, kind of both sides, legs, arms, often kind of coming up from the feet up, but that's not always the case. It can sometimes go the other way. But, thinking about different mimics too, in this scenario where, you do the nerve conduction studies and only the motor is affected, but someone's weak. You think about, botulism and like other things it could be. So we had to, we went back the next day to do nerve conductions again and do rep stim testing to see if there was any kind of nerve and muscle junction abnormality. And in that 24-hour period, all the sensory nerve conductions were affected then too. So that's where you get timing of the nerve conduction studies are kind of important to kind of consider. And so there's these loose categories of IADP, AMON, AMSAN, and there are kind of epidemiological kind of more in certain countries have incidences of AMON or AMSAN, but I think, and preceding infections and things, but I think that generally speaking, and based on the new guidelines for that GBS that were just came out, not really relying on those antibodies or the nerve conduction studies like wholly to kind of make the differentiation, because ultimately they're kind of treated the same.
Yeah, yeah. So two more variants, thoughts or questions to chat about, and then I promise we're going to move on to the mimics because we do have some questions on those. So for the variants, we got a question about, you mentioned the timing of the nerve conduction study, and I find this really, really interesting. So thinking of a patient who's maybe not progressing as typically as they think, or they're finding that their symptoms don't necessarily fit what they think is CIDP, do you think it's fair for them to ask the doctor about the timing of their nerve conduction study? That's my first question. Then there's kind of a second part to this.
For Guillain-Barré might be a little more relevant. For CIDP,
Gotcha.
yeah, I mean, I guess it depends if it was very, very early on, but usually that's going to be a scenario where, well, I mean, I guess I would say probably in that category, you have this kind of 5% of cases of what you think is Guillain-Barré is really acute onset CIDP. And so that gets into those gray zones of like kind of repeating studies. I think something that comes up a fair amount that isn't recommended is doing repeat nerve conduction studies like serially, like annually or something on a CIDP patient. I mean, we don't, we do those for diagnosis purposes. If things are worsening, if something seems to be evolving that's like atypical, we'll repeat them, but it's not, number one, it's not a pleasant test to go through. And then number two, I've had more than enough practice on me, so I know how that feels. And number two, like, I think it's not necessary because I think especially for, initial kind of Guillain-Barré, you have prognosis. Sometimes, patients still have symptoms and they seem pretty significant. And I'll repeat the study at that point, and it's very reassuring to see all the nerves look normal now. So like that means they're healing. And so that kind of be a scenario where you might repeat and see and to know that that's the case. But I mean, hopefully that answers the question a little bit, but I think
It does. It does.
Yeah.
And the second piece is still kind of tied up with the GBS. And can you distinguish between a variant versus just the typical GBS with residual symptoms? I'm feeling like that timing of the nerve conduction might be wrapped into some of this response.
I mean, we don't usually use the nerve conductions to distinguish the variants as much as the sort of how the symptoms are looking. And so say for the variant, that's the pharyngeal cervical brachial variant, that's where something like the blink reflexes come into play, which we wouldn't normally do maybe on the other studies. But I think those are probably helpful diagnostically. Sometimes they can look pretty normal early, very, very early on within the first like day or two of symptoms. And you might repeat it in a week and it might look very different, or like that 24-hour, because that's sort of more rapidly progressive. I think in the case of CIDP, at least the cases that I end up seeing, those end up, sort of, and we're kind of researching this a little bit more, but it doesn't happen immediately that someone's having symptoms, unless it's an acute CIDP case, where usually someone, because that symptoms are going to progress beyond 8 weeks, and it's usually going to be a couple months to like maybe even 6 months before someone gets a nerve conduction study, and by that point they're not on treatment, they will have met criteria. They probably would have progressed by then, but it depends, if it's really early. But you don't want to keep doing it over and over again unless you have a good reason.
Yeah. I think that message is loud and clear. And again, thank you for going through all of these. There's so many variants, and oh my gosh, I feel like I'm going to need flashcards to better learn and understand these.
Yeah.
So we did have a comment kind of, that these are all rare conditions and then the variants are more rare. So we're never 100% positive about the distribution of the epidemiology, but we're very grateful to IGOS, the International Guillain-Barré Outcome Study, and INCBASE, the International
Neuropathy Consortium. Yeah.
Thank you.
Mm-hmm.
I can never remember it.
Yeah.
As long-term studies that are helping us to better understand the distribution of GBS, CIDP, and all of these variants. And the foundation is really proud to support both of those studies.
Mm-hmm.
Okay, so I feel somewhat comfortable with our variants here, and I really hope that our viewers heard and learned something maybe about the condition or something that they're experiencing. But we also have what you called mimics. So that right now, I think in terms of the conversation we're going to have is anti-mag, and then some of these genetic forms or mimics: anti-neurofascin 155, anti-contactin. I hope I pronounced that correctly. So let's start with, why are they mimics? Kind of how do each of these get diagnosed? How do they present in the patient? And what makes them kind of under our umbrella, but not necessarily CIDP?
Yeah. Well, I mean, I guess I think about them in sort of categories of the variants and typical CIDP. So I think, and then, there's red flags that suggest an alternate diagnosis, and the kind of in those different categories. At least I'll start with CIDP. So I think, I don't know if I necessarily want to list things out possibly, but I think some of the highlights of things, say for typical CIDP, which is why it's recommended to check for SPEP immunofixation and serum free light chains to look for a monoclonal protein, is that sometimes patients can develop, acquired amyloidosis, or hereditary amyloidosis that can very much look like typical CIDP for a while. And so if you don't check for that, you're not going to see that. There are slight variations or things that evolve over time and different organ systems that get involved, but you have to kind of think about that as a possibility on the kind of list of possibilities, so that you can kind of keep that in mind as you're seeing, patients. And I think, different types of neuropathies, that can evolve. And there's kind of, a list of myeloma or sort of other things, that different types of like vitamin deficiencies or infectious sources that can be mimics of and look just like typical CIDP. In the distal category, we can get into the anti-Mag neuropathy. So those patients that have monoclonal proteins, and then of those that also have anti-Mag antibodies, those patients, that's a different sort of pathophysiology. It's like a different disease. And so, and amongst all the ones, when you're thinking about mimics, or like maybe this isn't really an idiopathic kind of case of CIDP, is that the lack of response to treatment. And so I think kind of paying a close attention to the clinical exam and the outcome measures are very important for guiding that kind of response to treatment, to make sure that you are getting a response to treatment, that grip strength is kind of stable or improving, or your overall disability scale or NCAT scores are stable or improving. And so assessing that kind of along the way kind of makes sure that you don't miss something that's a mimic, or is an alternate diagnosis. So that's that being said for kind of all the things. But I think, and then going into like anti-Mag neuropathy, that it just doesn't respond to IVIG or steroids very well. And those are two first-line treatments that it should be responding to. So when you have a lot, and so 80 to 90% of patients respond to the first-line treatments. So then when you get sort of a lack of response, then you kind of have to reassess and see where to go with that. So I think that's one of the ones where the distal CIDP can have that as a mimic. Certainly, like some of the hereditary neuropathies or Charcot-Marie-Tooth diseases can, and also amyloidosis or hereditary amyloidosis can look like symptoms where it's just the hands and feet are affected with numbness and weakness. Diabetic neuropathy, if it's very bad, diabetes can look like that too, which can be very confusing sometimes, because you can have both in the same patient. So that can be a little tricky sometimes. So, and then you can see kind of rare, like hematologic conditions that are treated with chemotherapy, and something very different called POEM syndrome, which is a whole spectrum of things. But, the major diagnostic criteria for that, they have their own categories for, but really it's the lack of response to treatment, or kind of an incomplete response where you're seeing progression over time. That can be a very hard diagnosis to make. And that could be a mimic there in that category too. And then the multifocal, sort of CIDP, and also the distal type, you can have like a vasculitic neuropathy where you have some kind of underlying rheumatologic condition, or some nerves being kind of taken out here and there in different distributions, and that's treated very differently than with the treatments we use for CIDP. So you have to kind of keep an eye out for that too. Different entrapment neuropathies, or like we were talking about, multifocal motor neuropathy, because that affects asymmetrically in the arms, because that has that sensory involvement. Usually that's going to be more of the Lewis-Sumner Syndrome with the sensory and motor involvement. But keeping that in the back of your mind and part of the differential at time of diagnosis and throughout, as you follow along with patients. The motor CIDP is tricky, because that could be a number of different sort of, if you think about localizing along the neurologic kind of system, you have the peripheral nerve, or you have the nerve and muscle junction that can actually look like a motor CIDP, but is a totally different thing. Or you can even have motor neuron disease or ALS that can look like that. So because that's a pure motor syndrome or just with weakness and no sensory symptoms, no numbness or tingling. And you can have a muscle disease that has the same look to it as just a pure weakness. So those are all things that it has even broader of a differential of things that you're thinking about for mimics. And I would say the sensory CIDP one, that's a little tricky too, but they can have entities known as CISP, where it's a chronic immune sensory polyradiculopathy that really has normal nerve conduction studies. It's very difficult, but there definitely is like these sensory symptoms and imbalance with blocking, and there's no other kind of contributing source of a vitamin deficiency or hereditary cause or toxin. And they have different testing that you can kind of look for to try to sort that out, but that can be a mimic of that too.
Yeah. The long list of things that can go wrong and maybe seem like CIDP really makes me think of the patient experience. So, what can patients do or say to their doctor to help kind of get to the correct answer?
I mean, I think it's so helpful to have, we really rely on like your report of like what you're experiencing and the chronology of it, like the timing of it and the evolution. And that's so important for determining like, if it's acute CIDP or if it's Guillain-Barré or, and those respond to different treatments too. So I think, and then kind of any kind of going through other symptoms that are going on, like if you, oh yeah, I also developed heart failure. I'm having, and that came out of nowhere. I had this family history of people with heart failure. Oh, and they kind of had neuropathy too. And then it ends up being hereditary amyloidosis. So going through kind of systems that may seem like they're not nerve related is still important to report because it's a whole like systemic sort of thing that you can, all the things that are going on that seem to be wrong. Like it's helpful to hear about so we can know, does it relate to this or not? Is this a mimic or not? Or is this kind of unrelated? And so it kind of helps to hear all that. That's very helpful.
Yeah, we could have a whole conversation on this, but I will refer everybody. We did an Ask the Expert speaker series webinar on this last year with Dr. Ruhoy about communicating for success at the doctor's office. So I highly recommend, if you want to have a conversation with your doctor about something is going wrong, and I'm struggling to communicate that, take a look at that, and hopefully that's helpful. I want to make sure we give some special attention to anti-mag, the NF155, and the anti-contactin, because we did get some questions about that. So can you tell us about anti-mag? And then we got, I lost it, but we got a question somewhere about antibodies with anti-mag. So hopefully you can cover that as well.
Yeah, so anti-mag neuropathy is a little difficult to study, I think, because it's a slow, sort of same sides are affected, so symmetric, so side kind of starts in the feet and hands and kind of progresses upwards. Can look like a lot of different things. Doesn't really respond to IVIG or steroids very well. There are like mixed review. The clinical trials didn't look all that great for the rituximab treatment either. But that in part is because of a little bit because of the way the trials were designed. So there's some new trials that are kind of in the works to kind of sort of sort that out a little bit better. And there's some other clinical trials looking at other drugs to look at that too, because and there's some school, there's actually, if people are kind of mildly affected, there's generally speaking, we don't use treatment for a symptomatic treatment and not immune suppression because the risks outweigh the benefits. And so I think that one is really difficult. I think if we don't follow the titers as much, if the titers drop by 50%, that could be potentially reassuring that your treatment's working. I tend to
sorry, the titers, you mean
of the anti-mag antibodies. So they do report when you order that in like a titer form. And so you might see, oh, it's over 70,000 or it's 50,000. And some people kind of follow those, but we don't actually know what that really means and the kind of granular detail of that. So I think sometimes I will check it to know that they're there, periodically recheck just to see what's happening, but I don't really know how to utilize that information so well unless there's a big change. So we kind of look at that, unless of course there's like, say, a lymphoma with MAG antibodies. So that's something always, I usually have hematology oncology consult and get involved and follow these patients with me sometimes, especially if there's a monoclonal protein and an anti-MAG antibody, just to make sure that there's not anything else evolving. Sometimes involves getting bone marrow biopsy and that sort of thing. So that's that particular entity. And then, interestingly, the anti-neurofascin and contactin antibody mediated disease was sort of more recently discovered as about 10% of patients that were diagnosed with CIDP. According to the new guidelines, it's now it's not considered CIDP because it's sort of the underlying immunology is different, and it responds to different treatment. So it responds to, it's IgG4 mediated, it responds to B cell depletion, like with rituximab, pretty successfully. So, and has either an incomplete or no response to IVIG and prednisone. So, and there's sort of different phenotypes that go along with that too, or how like the type, what it looks like when people are getting affected that was sort of defining. And so there's the neurofascin 155 patients tend to be a little younger, have more tremor, kind of in the arms more than anything, and then also have some more imbalance or ataxia. The anti-contactant, and sometimes can have a nephrotic syndrome, which is a kidney disease that kind of shows up too. And then the anti-contactant phenotype, or how that shows up, is a little less clear, but we do know that they have, a little bit more motor involvement or weakness, and a little more of the core of the nerve gets affected on the nerve conduction studies with that type. There's also a pan sort of neurofascin condition that there's just kind of case reports about now where people get very, very affected, just very, very weak, and sensory changes, just paralyzed, and respond to B cell depletion and sort of treatment like that. So it just takes a little bit longer to work. But I think those are important because the treatment is a totally different one. And I've seen a number, it's still rare, so you don't have a lot of patients with it, but of the ones that I have, everybody's, tried everything and it's just not working. Like they're on IVIG and steroids and they're still in a wheelchair, not working. And then, you start rituximab and there's definitely a demonstrable change in difference. So those antibodies are important to send to the right place for testing, and also to kind of keep in mind is what they call now paranodopathies instead of really,
Sorry, can you pronounce that one more time?
Yeah, paranodopathies, because it's actually the antibody attacking the paranode and the node at the site of the node of Ranvier, where kind of that sort of connection happens with the nerve kind of transmitting. So it's kind of a block to that connection. Yeah.
Yeah. That is interesting, and just more under the umbrella of kind of the things that seem to, the potential for things to go wrong in the peripheral nervous system. So you mentioned that it was something like 10% of what we thought were CIDP cases might be these other, are they the paranodopathies that we think? Is it all the NF155 and the contactin, or are there other things kind of within that 10% that we thought were CIDP, but are maybe not?
That's been the report of just the paranodopathy of the neurofascin and contactin. Yeah.
Okay. Interesting. So that seems like a lot.
I mean, I guess, yeah, a little bit. I mean, yeah, it's still pretty rare of the rare.
Right,
But,
right. Rare of the rare. Yes,
yeah,
yes, of course, of course.
Yeah.
And so just making sure I heard, but we knew that IVIG and steroids weren't really working for any of these mimics. Do you think that was how they first kind of got separated from CIDP?
Yeah.
Yeah, the treatment wasn't working and the presentation was looking like maybe a variant, but the treatment didn't work. And so rituximab was the first line and doesn't seem to work for anti-MAG from
Not as well. I think the reports of the clinical trial is 40% efficacy right now. I mean, that's what's been kind of the number that's generally reported based on the trials and things that have been done, the limited studies. I think future studies will be really important because it's obviously a debilitating type of neuropathy that needs other treatments. And so there's different targets and different targeted drug treatments that are kind of coming into trials to kind of design, and hopefully it will be helpful for that.
Yeah. I want to mention the foundation is hosting what's called an externally led patient-focused drug development meeting in May, and that's going to cover GBS, MMN, and anti-MAG. And so if you are an anti-MAG patient listening, please reach out to us because we would love some more anti-mag perspectives within that meeting. As we've said, it's the rare of the rare, so we're really hoping to make sure that the patient experience is authentically captured throughout that meeting. So thank you for letting me interrupt, and let's get back. We got a question about plasmapheresis. So where does that fit into this conversation for treatment of the variants and of the mimics?
So the plasma exchange should work for all the variants, probably not for the mimics because they're not, generally speaking. And plasma exchange, I think that's just a little bit logistically challenging sometimes, which is why it's not utilized, overly utilized. The evidence for, say, Guillain-Barré is that there's equal efficacy between plasma exchange and IVIG. So you can choose one or the other. And similarly, it's pretty much the same for a CIDP as well. It's just that oftentimes, I think in CIDP, the plasma exchange might be used for people who are kind of rapidly progressive and need to kind of turn things around a little quickly, but then it isn't great for maintenance because there's not kind of the access issues for getting to the veins. I mean, here we actually, because we also use that a lot for kind of crisis for it's my myasthenia gravis, which is a nerve and muscle junction disease. Historically, we have peripheral access, like kind of familiarity with our plasma exchange center. So we don't have to put in a central line to get that done, which is comes with its own risks. And so we have some nursing staff here that's very familiar in our plasma exchange center for doing peripheral access. So we can sometimes get away with doing it peripherally for a little while, but it just isn't great. So I think, yeah, so it's still considered a first line treatment, but just for at least for the CIDP patients, maintenance is you can't really use that for maintenance. Yeah.
Got it. Yeah. We got a question about a syndrome I'm not familiar with, so I'm probably going to pronounce this wrong. Canomad, CANOMAD.
Yeah.
Does that fall under GBS or CIDP variant?
That can be, and that's sort of a rare or sort of one that can fall under sort of either one, depending on how it presents. And then there's also like Canvas, which can under the sensory CIDP variant, which is, so those are, yeah, sometimes they're mimics. They're not really variants. Yeah. So,
okay. So we'll add that to our mimic. So,
yeah.
similar to what we did for the variants, I just want to do a quick rapid fire, like 5-word, 5-second summary of these mimics that we talked about. So anti-mag, can you remind me how it presents in patients and then treatment?
Yeah. So anti-mag is typically going to look like a mimic, like a distal CIDP. So hands and feet are weak first, but it does start to progress up a little bit more sometimes. But it's always predominantly affecting the hands and the feet with numbness and weakness. And for mild cases that say have no weakness or have some sensory changes, we just use symptomatic treatment. And then for people who develop more progressive weakness or involvement, we use rituximab. Yeah.
Gotcha.
So I will say some people that I've spoken with opt to do no treatment because they feel like the efficacy is poor. But I feel like if there's weakness, I'm in the camp of giving it a try since there's at least some 40% chance. Yeah.
Yeah, right. So rituximab is a B cell depleting, so it does create immunosuppression. Is that correct?
Yes.
So
Yeah.
you were saying before there's a risk-benefit ratio there.
Yeah. Mm-hmm.
Gotcha. And symptomatic treatment, is that just making sure that the person feels comfortable?
Yeah.
Pain management, things like
Like if
that.
the tingling is annoying or painful, yeah, using those kind of neuropathic kind of pain control drugs. Yeah.
Gotcha. Okay. Then we have the paranodopathies, the neurofascin 155 and the anti-contactin. What do patients experience, and then how are they typically treated?
Yeah, so most of those patients are going to look like typical CIDP. So numbness and weakness affecting both arms and legs, affecting the upper arms and upper legs and hands and feet. And so treatment is going to be rituximab.
Yeah, gotcha. Okay. Any secondary treatments for those if rituximab doesn't work, or?
No, so far, if it's actually truly, I send those antibodies to Mayo. If it's actually truly a neurofascin or contactin antibody mediated disease, it really responds pretty well to rituximab. I think if there's enough damage to the nerves, though, it might be hard to reverse some things, but that's going to be your best bet. Yeah.
Gotcha. And you did mention those are kind of newer conditions that we have identified. So I'm thinking that we still need awareness and research, and the foundation would love to aid in some of that awareness raising with the patient community. Great. Okay, this has been so great and so helpful. We have a couple just hodgepodge potpourri rounds of questions that I'm just going to scroll through. Oh, we did talk very quickly about the Anti-Mag syndrome. Can you just, remind me of what patients experience and then how does that get treated?
Yeah, so that is sort of a chronic, so there's kind of the acronym is like chronic ataxic neuropathy. Eye movement is affected. It has a monoclonal protein or IgM paraprotein. There's some antibodies that go along with that, some called agglutinins that go along with that. So I think the reason why, and there is it is a sort of affects the coating of the nerve or the myelin. So the nerve conductions can look a little bit like it. It's kind of more, and so, and those kind of, I guess the acronym really defines like the syndrome of what that looks like kind of on the sort of, clinically, you're going to see eye movement abnormalities and sort of this imbalanced sort of neuropathy that meets that criteria with the nerve conductions affected too.
Gotcha. Interesting. Okay. One question we have here. What blood work is used in the diagnostic process? So this specifically asks about the variant diagnostic process, but we can expand that, I think, to typical CIDP and then also the mimics. And then once IG therapy is started, do you continue that blood work and continue looking at any of that?
Yeah, I mean, I guess actually the blood work probably that would be the most useful would be the checking for the serum protein electrophoresis and immunofixation serum free light chains initially, and then and that's more or less to rule out sort of mimics. And I think usually we don't routinely recheck that unless there seems to be some kind of lack of response to treatment or for monitoring wise, I mean, just to differentiate between variants, I don't see that. Yeah.
Yeah.
Just that initially.
Okay. So we're starting to approach the top of the hour, but I just wanted to give a quick minute to, first of all, thank you so much, Dr. Gable, for that. I know this ended up being almost like a boards quiz or something about all of the variants, but this has been so helpful to better understand the, I think, constellation of CIDP and GBS and the other things that can go wrong with the peripheral nervous system. And I really hope that our viewers saw themselves reflected back and learned a little bit something about their condition. We went through a ton of different variants. So, that included the Lewis-Sumner, the distal motor sensory, and then we talked about the mimics and other things that could be going on that looked like CIDP but didn't respond to treatment, so are now in their own category. And we're seeing, as I think you were saying, that the mechanism of disease was a little bit different because they were attacking a different part of the peripheral nerve within the node of Ranvier. That's the paranodopathy. I hope that explanation made some sense. You're nodding. I hope so. So we got a ton of questions and we got to as many as we could. If we did not make it to your question, I do apologize, and please feel free to reach out to us and we'll do our best to make sure that you get an answer. I want to thank you again, Dr. Gable, for taking the time. I'm going to share my screen up here just so that if your question didn't get answered, the email address that you can send this to, info@gbs-cidp.org. February is MMN Awareness Month, so we're very excited to have a lot of virtual programming for MMN Awareness Month. Please stay tuned for that. We're also working on scheduling our next speaker series, non-MMN related, for MMN Awareness Month, which would be on pain, and we're very excited about that. I think that's all for today. Thank you again, everybody, for joining, and we will see you next time.
Thank you.
Thanks, Dr. Gable.